Hey, it's Jennifer Shepherd, and I wanted to share today neural tension and how I use it in the clinic, how I use it very, very often, pre-testing, post-testing, and how I use that information to guide my clinical reasoning, my problem solving, my treatment, and the effects of treatment. So what I wanted to share today was how I use neural tension to assess how I guided a patient with bilateral peripheral neuropathy. So very, very long story. Actually, a long time history of back pain from the age of 15. So that tells us right away. And actually, that initial incident way back when she was 15 was just from a sneeze. So as we know, right, a sneeze itself, here's the pressure on the disc. What was going on before? What was the trauma? What were the mechanics that were going on in her system that made her vulnerable for a sneeze to irritate the disc and start that cascade of back pain for her at the age of 15. She is now in her mid-60s. So several years ago, back in 2009, she was having a lot of trouble with sciatica, severe sciatica. And I think she had an epidural at one point and was just kind of lightly managed and did well. And that had somewhat resolved. And she came to me last December. It is now August, actually. And the sciatica was better. She still had a little bit of sciatica, but her primary complaint was numbness in her foot. So as we know, here's pressure on the nerve and how different pressures or prolonged pressures, again, and how someone receives pain or feels pain, and or when it goes to the level of numbness, again, how that nerve is being impacted at the different areas of the nerve root. And I cannot go into that science right now. I can look it up and bring it back to you. But anyway, knowing that as we have back pain or issues and we're dealing with a radiculopathy, how we want centralization of the pain, right? So again, when it's going down the leg, like we feel better when it's coming back up into the back. When it's down in the feet, bilateral numbness, and I told her, I said, I really want this to, I would hope that you almost experience a little bit more pain, bring it back to central. But where I wanted to go is MRI shows actually a significant central canal bulge, and then a significant right-sided bulge into the foramen. Hard for me to tell and hard for me to discern from the report whether is this bulge really sitting on the nerve root. Again, central canal, bilateral neuropathy, again, right more than left. So right, we've got enough on the MRI to bring us concern. However, how'd she get there in the first place, right? And then what can we do as manual therapists? Can we get enough tension off those nerve roots centrally to allow that nerve to be no longer under tension and to have an opportunity to try to heal. So as I'm treating her, again, okay, I'm not quite sure. Again, if there's a big disc sitting on a nerve root, sometimes you just need that microdiscectomy to get it off. I've had a couple patients where they just need it. I call it the nip and tuck. And then we're still working mechanics before and afterwards, but there's some things that just need surgical intervention. So for her, I'm not quite sure yet. So I used neural tension when she first came in. So I'd seen her back in December, and then there were some other medical complications, and she was not able to return just until about 3 weeks ago. Like I said, it's now August. So when she first came back, as I test neural tension, I gave her 25 degrees on the right side, which is not much. We want that leg to be able to come up to about 90. Can we come up to 100? And even more importantly, how's that end feel? How is it springy? Is it light? Or do we get I call it a first catch, because often we'll miss initial neural tension. We can blow past it and go into a muscular end feel versus here's that first catch of neural tension. So hers on the right side, I think she was 25. The right side was maybe 45. So significant neural tension. So I'm like, honey, we've got to get tension off this system. The question is the tension there because the nerve's irritated because of the disc bulges? And or as we look at the spine mechanically, neural tension, can be caused, as we often see, right? We see sacrum, coccyx, compression, and then over time, someone keeps walking, increased forces at L4, L5. So again, those increased forces tend to, and we can see it in the x-ray, and I'm sorry, I cannot pull the x-ray up right now, but when you see a sagittal x-ray, often you'll see the L5 vertebrae and the L4 vertebrae slightly anterior forward, and they come, sometimes they're pinched more in the back as they're forward this way, so like they're more open anterior on the front, more compressed in the back. Actually, that's where I usually tend to see it. But again, you can see where these forces that came from posterior, from the lack of a nominate extension, hip extension, regardless whether it came from coccyx or viscera from the front. Again, this lack of extension through the pelvis created increased shear forces at the 4-5, 5S1. So again, here's these nerve roots coming out, and here's this anterior shift, anterior shear. I know in my own body, when my L4 goes into anterior shear to rotation, when I play more tennis without my SI belt, I'll feel it down my little nerve root line. So then that's when I know I need to get in there. I need to work AP, get that vertebrae back again, and then restabilize my pelvis, get my core firing, and just keep myself solid inside and out. But so coming back to neural tension, so that wasn't great. We need to get that neural tension clear, because again, right in the hierarchy of the body, body will protect an artery, blood supply to the brain or an organ, and then also will also protect dural. And where I learned this the hard way was I had a patient come in probably 10-15 years ago, and from one of my personal trainers, and yep, I'm having some back pain. And so I watched her walk, I watched leg swings. I'm like, yep, let's go ahead and restore the mechanics of your pelvis. So I went into coccyx, sacrum, restore that nominate extension, AP lumbar spine, and then leg swings were cleaner and better. She was walking clear as she walked out the door. So 6 hours later, she called me, oh my gosh, Jen, my pain is terrible. So that was my first lesson, again, with this flare-up of a patient, how I helped restore articular mechanics, some fascial components as well, but right. So I restored mobility of the pelvis, restored mobility, position, alignment of the lumbar spine on the pelvis, and she left moving great. However, as we look at the underlying dural system, that increased the tension on the dura. So, we kind of go back and forth, chicken or egg, right? Are some of the articular things that we see, are they protective strategies for the dura? Like if there's tension on the dura, is the body going to find a way to, I'm going to find a way to get tension off of it. And I find this often, especially as we go into vascular, and I don't want to tangent into another story, but back to how the body will always find a way to optimize those blood vessels and blood flow at the expense of something else. So anyway, for this woman, I learned very quickly, I pre-test and post-test neural tension before and after, and I always want to make sure that I don't lose neural tension after I've treated. So that's what happened today with this patient. So 2 pieces with the neural tension. So we're discerning, can I, again, yes, so she needs to have mechanical treatment, but the question is, does she need to see a neurosurgeon to address this piece, or is manual therapy alone enough to get tension off the nerve roots? Again, with neuropathy, even if we get enough tension with, with mechanical work, it's still going to take a long time for those nerves to regenerate. So again, it's one of those, well, we can see that mechanics are better, but as far as symptoms, nerve-wise, that's going to take quite a while. And if there is still something sitting on that nerve that I can't address with my hands, I want it off for her, because we need to get pressure off that nerve. So that's kind of where I'm trying to make this decision. Do we send her out sooner to look a little bit closer? She's seen a couple other doctors and she hasn't really gotten anywhere, but I am concerned about this bilateral neuropathy for her. And she's also had diabetes ruled out, all those other pieces ruled out. So, but back to neural tension, I told her, I said, if I can improve that neural tension, and if you keep it the following week or a couple days later, that gives me more confidence that I was able to get some tension off the nerve, versus if I improve the neural tension mechanically, and then a few days later that neural tension came back, takes me back into, hey, there is still something sitting on that nerve, and that nerve just kind of, whoop, I'm going to tighten right back up to protect that, or there's an irritant on it. So as she came back in, she kept the neural tension gains that I made. So the last time I'd seen her probably 3 times since she came in with 25 and 45. The last time I saw her, a session before today, she left, I think she was in at 45 and 65 neural tension, so it was getting better. And then as she left, we were at 80 and 90. So we made a big gain in neural tension. I just started mechanical work with her last time as well. And again, I tend to start more with the listening. I tend to work more visceral vascular initially, dural, and then as I start to get tension off those systems, then I come out into the more articular system. Just because of that experience I had, right? Going gangbusters on the articular, and if there's something inside on the visceral vascular neural level that says, I can't handle that increase in range of motion that you just gave me, it's going to tick something off. It's going to create a reaction, whether it's a pain response or in a combination somewhere else. Again, the body's brilliant and will always find ways to protect, right, those very vital internal structures, right, at the expense of our externals. So anyway, she came back in a couple days later. I saw her Tuesday. I said, I want to see you Friday because I wanted to make sure, you know, how did you keep this neural tension? And she did. So I was much more encouraged that we can do a lot. Of course, we can do a lot, you know, mechanically, manual therapy, but again, less concerned about that disc sitting on her nerve root directly. And back to perhaps maybe, you know, by restoring the mechanics, we can get tension off that nerve. All right. So, so then I treated her today. I had some listening, but I let the listening go today, and I just went straight into mechanics. So she absolutely, we've got some more coccyx work that we need to do. Abdominal extension is okay, and actually the restriction there is more at the coccyx. So I absolutely need to get a little bit deeper into coccyx, distract that, decompress the sacrum. She also had left femoral artery into iliac artery, more so femoral artery, so I definitely had some arterial pieces that I needed to get tension off through the left pelvis. A lot of tightness through the inguinal ligament on the left more than the right. So, and then I went AP, still working AP, L5, AP, L4, central, slightly to the right, work those back. So I get her back up after all that great work, and I retest neural tension, and I lost some. So I said, you're not done yet. I got her back down the table. I went back into sacrum, and most of my dural work these days is a little bit more through the listening, listen and follow, a little bit lighter as we work on the dural layer. So I did work back through, and you know, back to as we, like, every action has a reaction. So as I, you know, did so much mobility, that actually increased a little bit of strain on the dural system. So then I had to go back out and then tease out the dura. So I see this actually in many patients as I work back pain, how like we work the articular and then the dural, and then again, how did the dural respond to the articular? So it's this dance, you know, inside the body, outside the body, you know, how's the inside doing with the outside? But just to emphasize the importance of neural tension and what a diagnostic tool, how phenomenal it is to give us information on, you know, what we're dealing with system-wise, right, dural tension, and also to guide us in our treatment, to guide us in our clinical reasoning, right? How does it change? When do we keep it? When do we lose it? To guide us in what's that next best decision for our patients. And then lastly, for our treatments, right? When we lose that neural tension, something happened here, we lost it, what happened? And then diving back into restoring that neural tension, or just trying to understand why did we lose that? What was going on mechanically that we changed that created this increased tension on the dura, because we don't want to flare our patients up. We don't want to I never want to send you home with worse neural tension than what you came in. So again, if that's the case, then we dive into what happened there, what's going on anatomically and physiologically. So thank you for joining me. I love sharing patient cases and stories, and look forward to your questions.